Ladies and gentlemen, good afternoon. I welcome you to this session on day versus night, new perspectives on stroke prevention with home monitoring tools. This is a symposium by OMRON, and we thank this company for giving us this opportunity to discuss several quite hot topics with new data. So I'm talking on behalf of my co-chairman and the first speaker, Gianfranco Parati from Milan, who will talk about the importance of nocturnal blood pressure monitoring and systematic screening for atrial fibrillation. Professor Parati.
Thank you, George. In this meeting, we've been discussing many times on the importance of controlling hypertension to prevent cardiovascular disease. And in this meeting, we want to focus on some more specific aspects of this issue, which is the importance of controlling blood pressure also during night and the relationship between hypertension and atrial fibrillation, because both of them, as you know, are contributing to the risk of stroke. These are my disclosures. So we need to reduce the burden of cardiovascular disease and in particular of stroke, and we have very clear evidence from many studies. First of all, the World Stroke Organization held a meeting a few days ago. I was in Geneva for this meeting, participating to this event, and we are emphasizing the numbers. You see, around 12.2 million incident cases of stroke. 1 out of 4 people will have a stroke in their lifetime. It has been increasing in the last 20 years. 143 million disability-adjusted life years lost, 6.6 million deaths globally. So it's the second leading cause of death and the third leading cause of disability worldwide, with a huge cost, 451 billion. So that's not a negligible aspect. And hypertension remains a stealth killer and a major contributor to these particular events. So we have again some numbers to consider. As I said, we are facing something affecting 1 billion of people in the world, hypertension. We know that hypertension is highly prevalent in a combination with atrial fibrillation in adults older than 60 years, and the risk of atrial fibrillation increases with age, with other cardiovascular risk factors, and hypertension as well. If you combine atrial fibrillation and hypertension, you are almost doubling the risk of stroke, which means that preventing stroke becomes a top priority for us, mainly in people prone to also have atrial fibrillation. And that's why we should try to focus, and that's why we organized this meeting, on 2 aspects. One is controlling hypertension better, and we know this is not a goal achieved fully in the world. And second, how to screen for atrial fibrillation, to identify those cases which are asymptomatic. And this is not just the present or the past, it's also the future. You see here a projection to 2040, where you see that hypertension remains the leading cause of years of life lost. That's, again, something that we may expect to increase also due to the contribution of low and mid-income countries, where non-communicable diseases are becoming more and more frequent. And when you focus on hypertension control, we know that we have several components to hypertension that are contributing differently to the outcome. We know that's an old slide from the Stergiou study, but that was focusing on elderly people under placebo, so we could check the events rate related to high blood pressure better. And we found clearly that office pressure is a predictor, but is a weak predictor. You get something better with daytime pressure, the 24-hour, but the best predictor was nighttime blood pressure, which is again emphasizing the importance of taking care of blood pressure at night. So importance of nocturnal blood pressure monitor is not trivial, because many people don't care. And I remember some years ago, the NICE guidelines in UK, they were recommending ABPM only during the daytime. It was a big mistake, because you lose information in this regard. Recently, we had the Spanish registry. Professor de la Sierra was contributing directly to this, and there was evidence on more than 59,000 people that nighttime pressure was a better predictor of all-cause mortality than daytime pressure with the blue and the green dots. And that was the case also for cardiovascular mortality. So again, evidence from a very large data set that we need to take care of nighttime blood pressure to prevent mortality and events. And that's another interesting study by Professor Cario, focusing on nocturnal blood pressure measurement with the home devices, a new technology available. And they were quantifying the nocturnal level of pressure, and they found that the survival-free of event, considering separately total events, stroke events, and coronary artery disease events, was worse in those with the highest level of nocturnal blood pressure, even when measured with a home device. You can also focus on the changes between day and night, so not only levels, but also dipping. And there's an old paper from the Oasama study, it was one of the first in this direction, showing that if you are non-dipper, or even worse, inverted dipper, so-called riser, you have a significant increase in all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality separately considered. The Pamela study was providing evidence in a general population north of Milan in the same direction. Cardiovascular mortality over a 12-year follow-up was increasing when there was an increase in daytime short-term variability, but also when there was a reduction in the dipping at night, separately considered. And finally, if you consider another recent paper coming from the group of Professor Cario, you find that considering different patterns of nocturnal blood pressure change, the inverted dippers or risers and the non-dippers had a higher risk of events, and in particular of heart failure events, as shown in this slide. So from many different studies, we have a clear evidence that this is important, and we have to take care of blood pressure at night. That's a kind of summary, nice paper by Professor Palatini, combining the impact on cardiovascular outcome due to an increase in blood pressure variability and a reduction in dipping. And the colored chart shows that the highest risk is due to the reduction in nocturnal fall, combined with an increase in short-term blood pressure variability, all patterns that we are not commonly considering in daily practice. On the other side of the coin, we have the contribution of atrial fibrillation. This is important because we know that a very prevalent disease is associated with a number of cardiovascular complications, including heart failure, vascular dementia, stroke, thromboembolic events, depression, and mortality, something very well known to all the cardiologists here. The European Society of Cardiology in 2020 published this important paper on the management of atrial fibrillation, where there was a specific emphasis on the importance of detecting asymptomatic atrial fibrillation. Why? Because this is a very prevalent phenomenon, and in many cases, people are completely asymptomatic the first time they have it, and even recurrences are commonly asymptomatic. There is also quite evidence that the embolism associated with AFib is also frequent when they have comorbidities, but also whenever they have the appearance of the arrhythmia, even without classic symptoms, or something you have to screen for. And they were showing quite worrisome data that regardless the fact that atrial fibrillation was asymptomatic or symptomatic, it was associated with an important increase in mortality, in stroke, in heart failure, and was predisposing to vascular dementia in the follow-up. So very good reason to take care of this seriously. So we have two issues here to face. First, the importance of screening, which means identifying the arrhythmia before any clinical manifestation, and mostly in the asymptomatic people. And then, of course, confirming the diagnosis. This paper, the position paper of the ESC, was suggesting a opportunistic screening in all people older than 65 years of age, accompanied by recommendation on how to manage the arrhythmia. It's not enough to detect it, you have to manage the arrhythmia properly in terms of preventing thromboembolic complication and completing the diagnosis. And also they were recommending a structured approach to collect the data and to organize a systematic management of these people. And in people older than 75 years, they were recommending a systematic screening. So opportunistic, systematic screening depending on the age, but in both cases, you need to confirm the diagnosis, which is recommended to be obtained by using either a single lead ECG or at least 30-second duration of the recording, or having a 12-lead ECG, which is more complete and more comprehensive for the diagnosis. So, just to conclude this brief introduction, why should we then measure blood pressure during sleep? First, because this is a quantitatively important phenomenon in our life. We spend 1/3 of our life more or less sleeping, that's important to consider, but also because the nocturnal blood pressure has a number of important implications. First of all, it offers information on cardiovascular control during sleep, in health, but even more so in disease condition, where sympathetic or vagal activation might change. It allows to diagnose spatial phenotypes, such as masked hypertension due to isolated nocturnal hypertension, allows to check the occurrence of a smooth control that you might obtain with your treatment, covering the 24 hours and also in particular the night in an effective manner, either by using drugs or device-based treatment. Has a strong prognostic value. You have seen my slides before. And the question is, and this symposium will try to give you some answer, how should we best assess nocturnal blood pressure patterns? We have several possibilities that my colleagues will describe in their talks. On the other side, the second question is, why should we then screen for atrial fibrillation? Well, we have seen some data. There is an increasing prevalence of atrial fibrillation. Previously unknown AFib detection covers 10% of all ischemic stroke, the so-called cryptogenic stroke, depends often on this arrhythmia. There is high prevalence of asymptomatic atrial fibrillation, and the potential to prevent strokes related to atrial fibrillation with appropriate treatment depends, of course, on how well you detect and how early you detect this arrhythmia. Asymptomatic clinical AFib is independently associated with a higher risk of stroke and mortality compared with symptomatic AF because people are not aware and they are not covered by the proper treatment. And again, the question here is, how should we best screen for atrial fibrillation? And my colleagues will discuss also this issue more in detail. So I was just introducing this topic. I just want to remind you what the World Stroke Association is strongly emphasizing. We should all work to improve stroke prevention, treatment, rehabilitation, and support. And this can be effectively done by having more accurate blood pressure measurement, including nocturnal blood pressure monitoring, and by a more effective and wider implementation of screening for arrhythmias. So this will be the topic of this meeting. I thank you for your attention, and we will have a discussion in the end, try to combine these two important aspects that might lead to a higher rate of important complication in our patients. Thank you.
Thank you, Professor Parati, and we will go into the details of these topics, nocturnal hypertension and atrial fibrillation screening. And Professor Pengo will talk about silent surges, unraveling the impact of nocturnal blood pressure fluctuations.
Thank you, Professor Stergiou. Thank you for the opportunity of presenting some data and to discuss about the topic which is something that I've been involved with for some time, as my background is basically cardiology, but also sleep medicine. So I'm fascinating about what happens during the night, during sleep actually, because as you know very well, we can sleep also during the day, and hopefully you won't do that, particularly now that we are after lunch. We might have some daytime sleepiness. So we are going to touch a couple of concepts which I think are important, particularly now that the focus on nocturnal blood pressure is high compared to perhaps to previous years. And we know much more about what can cause nocturnal fluctuations of blood pressure during the night. So I will connect with the previous presentation, trying to address the question, why are we focusing on nocturnal blood pressure? We have plenty of evidence now confirming that indeed nocturnal blood pressure holds an important predictive value, and this has been seen in different studies and in different populations. So I believe this is now a concept that must be taken for granted, for crystal clear to all of us, because again, probably what happens during the night in terms of blood pressure fluctuation really holds important message when we evaluate the risk of our patients in clinic. Now, we obviously are looking at absolute values, but we are also looking at variations of blood pressure during the night. And you know that there are plenty of studies confirming that indeed the fluctuation of blood pressure, so the so-called blood pressure variability, holds itself an important prognostic information. This is a study by Professor Parati that again confirms that if you try to dichotomize patients according to their short-term nocturnal blood pressure variability, what you will see is that those with high blood pressure variability at night will tend to develop cardiovascular events in the future compared to those with a reduced standard deviation of nocturnal blood pressure. So again, not only absolute values, also blood pressure variability at night during sleep are of interest to all of us. And what's behind all that? Well, we all know from many position papers and guidelines that there are plenty of things that can really have an impact on blood pressure fluctuation at night. This slide summarizes the different domains. So we have lifestyle domains, so the exercise before going to bed, coffee intake, alcohol intake, everything that regards our lifestyle can have an impact on blood pressure fluctuations. Then we have environmental factors, everything that involves the room where we sleep, the temperature, but also issues and variables related to the device itself and the position that we assume during the night. And last but not least, many clinical factors. We know that many patients with Parkinson's disease that develop issues in terms of autonomic dysfunction tend to have issues at night and to develop nocturnal hypertension. And similarly, other clinical diseases, chronic kidney disease in particular, certainly play a role in terms of the development of nocturnal hypertension. But if you look closer, there are a lot of things that involve sleep, right? So the quality of sleep, the duration of sleep, the presence or absence of sleep disorders, and everything can indeed play an important role. So sleep apparently is an important determinant of blood pressure at night. And we know this since ages, because Professor Mancia, back in the days together with the group in Milano, showed us quite clearly and stated that the most important factor that allows blood pressure to drop during the night is the presence of sleep, regardless whether it occurs during the day or during the night. So again, if we sleep, then our heart rate, our blood pressure tends to slow down, and we know that there are important implications that connect the sleep quality and sleep duration with nocturnal blood pressure. This slide summarizes how complex and intertwined the mechanisms are, because we have mechanisms related to sleep architecture itself. In this slide, you see a hypnogram with all the different sleep stages, and you see that during REM sleep, we tend to have high heart rate, higher blood pressure, whilst in deep sleep, the non-REM sleep, blood pressure tends to slow down. And obviously, we don't see these fluctuations very often when we record our blood pressure using an ABPM, because obviously these are seen if we can capture blood pressure fluctuation with a beat-to-beat device, for instance. So again, what we see in our clinic when we see our ABPM tape is just a sum of different things, an average of different aspects that can indeed alter blood pressure at night. So we said the sleep architecture, circadian rhythm can be relevant, of course, as well, and the microstructure of sleep. So if we have an arousal at night because of, of apneas or other things, we have a cortical activation of our brain, we have changes in the EEG, and then we have an associated rise in heart rate and blood pressure caused by an enhanced sympathetic activation. So all these different pieces work together and are responsible of nocturnal blood pressure at night. And then we have sleep disorders, obviously. If you sleep okay, if you don't have any problems falling asleep or sleeping during the night, then your blood pressure should drop physiologically. But if you have sleep problems, then we know that particularly for sleep disorder breathing, which is one of the most studied sleep disorders, people with these apneas tend to develop a riser pattern of blood pressure and nocturnal hypertension. But not only sleep disorder breathing, also insomnia tends to alter the circadian, the diurnal blood pressure rhythm. This slide shows you that patients with insomnia tend to have high nocturnal blood pressure regardless whether they sleep or not, obviously. Meaning that in patients with insomnia, there is a sort of a hyperarousal that enhances the activation of the sympathetic nervous system. So how do we evaluate blood pressure at night? Well, we know the current approach is ABPM based. We take a snapshot of a 24-hour blood pressure profile. We see the changes during the day and during the night. We identify phenotypes. We have a lot of information actually from our ABPMs. We can understand whether the patient has masked hypertension, white coat hypertension. We can see blood pressure variability. We can see many, many things. However, this is just a snapshot. It's usually done on one day only. We have to assume that that day is the normal day for our patient, but usually it's not, because sometimes the patient can be bothered by the device, or perhaps on that night they couldn't sleep that much. So what you have is a snapshot again of your nocturnal blood pressure that you have to interpret in a way. So this approach certainly has some advantages, but do have some limitations as well. One of the most relevant is certainly the reproducibility of both nocturnal blood pressure and also the dipping pattern. If you repeat your ABPM a few times, you can see very different things. And again, this is something that we have seen also in clinical and research studies. Sleep disruption still represents a problem for some patients. Some patients cannot tolerate, cannot bother wearing the device overnight. And therefore, the BPM is not always well accepted by patients. And last but not least, the limited availability. Although in many hypertension clinics and hospitals, ABPM are there and we can use it, but remember that in general practice in particular, this technique is not always available. So are there any alternatives to ABPM? Yes, there are some. These are some of the alternatives that I assume are well aware of. They allow us to measure nocturnal blood pressure, avoiding running an ABPM tape on our patients. So these are devices that can be programmed automatically to measure blood pressure at different time intervals. And obviously they need to be connected, the cuff should be connected to the device. So the patient needs to sleep with the cuff on, connected to the device. Do we have any data on nocturnal blood pressure measured with these devices? Yes, we have some data, some interesting data actually coming from Japan. And the J-HOP study showed us that apparently it looks like, according to this study, that nocturnal hypertension determined with a home blood pressure device has a strong predictive value when compared to nocturnal blood pressure measured with the ABPM. You see in these slides that apparently for some endpoints, there is no clear difference between a patient with nocturnal hypertension and nocturnal normal tension when measured with the ABPM. On the contrary, it appears that the difference is quite clinically significant when you manage to measure blood pressure at night with a home blood pressure device. So there are other alternatives. I'm sure you are aware of the night view device by OMRON, which is a wrist device that can measure blood pressure at night. It has some advantages compared to the other two devices we have seen, because there is a standalone device, so there's no cable, nothing that can bother the patient at night. It's a wrist device, and so some patients can find it more comfortable. And there are some technical aspects that can certainly, that needs to be mentioned, particularly the structure of the cuff with a particular sigma cuff that improves the occlusion of the artery, and an algorithm for supine blood pressure measurement as well. So this device has been validated according to the ISO protocols, and apparently the blood pressure measured with this device passed the validation paper. We wanted to understand and to see if in clinical practice this device can be of help, and in particular if it can be tolerated by patients. So we ran a little cohort study in Milan in 173 hypertensive patients. You see 58% males, mean age around 60 years, and in the overweight range of BMI. And you see that when we measured blood pressure as office blood pressure this time, so not nocturnal, there was a modest concordance with the standard office blood pressure measurement. So apparently the measurement that we get compared to the standard ones are quite comparable. That's certainly a good news. We also wanted to understand whether this device was bothering the patient during sleep, and it was accepted during sleep by the patient. So on one side, we asked the patient whether they were disturbed by the device during sleep, and as you can see, all patients that use it for quite a long time, because we managed to follow these patients up after 1 week, after 6, and after 12 weeks. And most of them were happy with the device, and they could sleep with no problems. We also conducted a polysonographic study where we asked the patient to use the device during a full polysonography. So we measured the EEG, and all the parameters that we measured during polysonography, respiration, oxygen saturation, etc. And as you can see from these artifacts, which represents when the device was working and performing the blood pressure measurement, basically the patient did not wake up. So there were no arousals prior, during, or after the blood pressure. So this is a one patient only, but in our cohort of patients, 90% of the patients did not have any arousals during the night, which is reassuring, because that means that overall the device is doing its job and is not waking the patient up that much, and this may in a way give us a better picture of nocturnal blood pressure, perhaps, if the patient is not waking up during the night many times. So we also performed a reproducibility study, which I will present later this afternoon, so I will invite you to come and discuss about this, because obviously this is a hot topic. It's something that might be useful for our clinical practice in the future. So it's good to have all feedback from colleagues, from expert colleagues like you about this topic. So to conclude this brief talk, I think that, again, we have seen that nocturnal blood pressure holds important information for stratify the cardiovascular risk of our patients. There are different factors that influence nocturnal blood pressure values at night. Certainly the presence of sleep, as we have seen from the seminal studies by Professor Mancia, causes a nice drop of blood pressure at night, and the presence of sleep disorder can impair this drop. So the IBPM approach has allowed us to study blood pressure at night for many, many years. It has some advantages, but also some limitations, as we have seen. So we have now good alternatives that might be interesting and useful also for clinical practice. Future research will need to understand whether this approach can be, in fact, extended to clinical routine in the management of patients with hypertension. And I thank you very much for your kind attention.
Thank you, Martino. We have the discussion at the end. So now it's my pleasure to introduce my co-chair, Professor George Stergiou from Athens, who is going to provide an answer to the second question. How can we perform a screening for atrial fibrillation in a better and more effective way? Please, George.
Thank you, Professor Parati. I'm glad this afternoon to talk to you about new tools for atrial fibrillation screening, tools which are here and are underused. And this is my conflict of interest declaration in relation to this lecture. So I don't need to explain to this audience the risks associated with atrial fibrillation. And I would like to show you a paper published, a statement by the ESC, and they said that despite marked progress in atrial fibrillation management, its detection remains difficult, and AF-related complications cause unacceptable morbidity and mortality, even on optimal current therapy. I'd like to add here, cause preventable and unacceptable morbidity and mortality. And they said that new evidence supports a simple, scalable, and pragmatic population-based AF screening pathway. And they gave this scheme, which says that if you are older than 75, you need systematic screening for atrial fibrillation with a tool. If you are younger than that and you have these comorbidities, which increase the incidence of atrial fibrillation, then if you have comorbidities, certainly you need systematic screening. Otherwise, you need opportunistic screening, and this applies also to younger people in the presence of comorbidities. And we do have a lot of tools today for atrial fibrillation detection. You can see here a variety of devices, portable devices, wearable devices. Some of them use a PPG signal, which is actually screening. Some of them use ECG signal, which is actually diagnostic. And these are the studies which the companies producing anticoagulant drugs have used. And you can see in these studies, about 60, 70, up to 80% of patients were hypertensive, which means it makes a great sense while screening for hypertension or monitoring hypertension in the same time to screen for atrial fibrillation. And this is a paper we published a few weeks ago in Hypertension, and we present the evidence and quite strong evidence we have today on how automated oscillometric devices used for home or office monitoring can, in the same time, effectively screen for atrial fibrillation. You can see here there are 2 office, 18 home, and 3 ambulatory monitors. There are 23 studies, most of them in Europe and Asia, and there are 11,000 people, which means that we have a lot of knowledge and data on how these devices perform in detecting atrial fibrillation. And here you can see several companies involved in developing such devices. And this is the analysis of the evidence. You can see most of the devices are designed for home measurement, but in fact, these studies tested them in a setting, in office setting. Some devices are professional office monitors, and few are ambulatory monitors. And collectively, you can see an impressively high sensitivity, 97%, and specificity, 93%, which is convincing, solid evidence that these are very accurate screening tools for atrial fibrillation. And from this paper, we concluded that if we agree that we have a population with 5% atrial fibrillation, then we have 50 out of 1,000 patients developing atrial fibrillation. And these technologies, of these 50 patients, will miss one. And from the 950 without AF, they'll have 65 which will be unnecessarily referred to ECG, which is a very good performance for a screening tool, not diagnostic, screening tool for atrial fibrillation. And interestingly, this technology can be implemented in ambulatory monitoring. So you have, let's say, 100 opportunities within the 24-hour period to detect intermittent atrial fibrillation, and we came out to some recommendations on what proportion of readings with atrial fibrillation is enough to say this is a screening tool and you should go for 24-hour ECG. Here is another technology. This is, again, a blood pressure monitor, but this does not have an algorithm for assessing the rhythmicity of pulse rate, but direct assessment of ECG. And you can see here, this device has very high specificity and sensitivity, of course, because this is ECG-based. And I think it makes very good sense in population with high risk of AF, particularly people aged older than 60 with hypertension, to monitor and screen simultaneously for blood pressure and atrial fibrillation. And you can see how the device works. You put your fingers and you have a full ECG lead, and you have automated interpretation and diagnosis in your pocket in your mobile phone. And this is a small study where people had ablation for atrial fibrillation, and they were followed for 12 months for possibility of AF recurrence, and half of them used daily the OMRON BP with ECG, and half of them used the usual care with having 24-hour ECG every 3 months. And eventually, the OMRON device actually was able to detect twofold more common recurrence of AF. And the time to the first AF detection was by 41 days shorter, and those people who had frequent measurements, daily measurements, had much higher benefit. And you can see here the advantage of following the possible recurrence with this device, and you can see the benefit of those people who regularly screen themselves for atrial fibrillation. And this is a study done in Kyoto with this device. These are elderly people, older than 65, 1,600. And in this general population of the elderly study, they identified 58 people who already knew that they have AF. But they also identified 70 people who were undiagnosed. And they were detected because they are lucky to contribute to this project. And here we move to another level. This is a paper published last month, which is again the blood pressure monitor, but this time it uses a novel machine learning algorithm to detect atrial fibrillation. And you can see it's a big study. Half of the people had atrial fibrillation and others did not. And there are 2 devices by OMRON with this machine learning algorithm for atrial fibrillation detection, and also a microlife device with AF detector was used, and of course, reference 12-lead ECG was included. And this is the machine learning approach. Don't expect me to explain to you exactly what it is, but here are the results. If you look at the microlife device, the classic algorithm detecting atrial fibrillation, you can see an error 3.6%, a very, very reliable device. But if you look at the machine learning device, the algorithm gave almost 0 error. And if you look at the specificity, was very high with both the microlife and the machine learning device, 98%. The sensitivity in this direct comparison was superior with the machine learning device, and eventually the accuracy was significantly higher. So here is another technology, maybe more accurate than what we have, and it should improve our ability to reliably identify and diagnose atrial fibrillation. And this is the concluding table from our paper, which says how we can use the blood pressure monitors today in the office, at home, and with ambulatory monitoring to screen for atrial fibrillation. So in the office, it is a kind of opportunistic screening and during the routine office visits, and you can detect permanent AF. Think about the risk of using automated devices in the clinic. A patient comes to the clinic, he has atrial fibrillation, but if you don't use your auscultatory method, or you don't examine him, he comes to the office with AF undetected, and he leaves the office with the AF undetected. Home monitors, I think it's an ideal tool for those people who have high probability of atrial fibrillation, the elderly or younger people with predisposing conditions, and they have hypertension, and they monitor home blood pressure anyway. It's a great opportunity for early detection of undiagnosed, asymptomatic atrial fibrillation. And ambulatory blood pressure monitoring, when it is used in the elderly for hypertension, why not screen for intermittent atrial fibrillation? And I would like to close here with presenting you this organization, the AF Screen Organization. This organization promotes discussion and research about screening for unknown and undertreated atrial fibrillation. It provides advocacy for implementation of AF screening programs tailored to the medical systems of individual countries. And it looks at the role of new technologies implemented in healthcare systems to screen for atrial fibrillation. And it is operating in 37 countries. And this organization is almost completed a statement which is exactly about this topic, simultaneous screening for hypertension and atrial fibrillation. Thank you for your attention, and I'd like to invite you to the next ISH meeting in an exotic place, which is Cartagena, Colombia. Thank you.
Thank you, George. Martino, can you join us here for the discussion? We have some time for discussion, so if you have any question, you are welcome to ask now. Just to break the ice, I have a question for you, George. You mentioned the possibility of using the oscillometric approach with office, home, or ambulatory to derive from this indication on the presence of arrhythmia. So which method is, in your view, more applicable for the screening of atrial fibrillation in daily practice?
First, I think whenever you use an automated device to measure blood pressure in elderly people, older than 65 or younger with diseases which increase the possibility of AF, I would like to have on board an AF detector. But specifically for hypertensive people, the older people, it would be ideal in the occasional measurements they do at home to be able also to screen for atrial fibrillation earlier than waiting to go to the doctor or having a stroke. So for long-term monitoring of hypertensive patients, I think home monitoring with AF detector is ideal.
And of course, this should be followed by clear indication that they have to confirm the diagnosis, going to get an ECG done. Obviously, it's not something that can be concluded only with the blood pressure measurement.
Yes, but I think most people do not realize the very high diagnostic accuracy that these screening tools have. Most screening tools which we have in medicine do not have so high diagnostic accuracy. However, you wouldn't ever prescribe anticoagulant therapy or investigate unless you have ECG confirmation.
Please, a question there.
Thank you very much for the excellent presentation. My name is Augustine. I'm from Nigeria. My main question is about the training of the algorithm for detection of atrial fibrillation. Did it consider those with paroxysmal atrial fibrillation, which if you do ECG at the time they come to the clinic, it may be normal, but they may have periods of atrial fibrillation, which is even the more dangerous one as far as stroke is concerned. Thank you very much.
Of course, paroxysmal atrial fibrillation is, it can be missed by all these technologies, and ideally you should have a wearable device which monitors you all the time if you are at high risk for this. And I think something like this will come out soon. But this is for people with high risk of this condition.
And that's very important because some people do have short episodes during the 24 hours and they don't give importance to this. And in some of them it's really very poorly symptomatic, so they think it's something else. They don't even consider this possibility and they might have a stroke because this is not managed properly. So that's a really important feature. Please.
Thank you very much for interesting talks. I'm Job van Sekensen from the Netherlands. I have a question about the nocturnal blood pressure monitoring. So there's quite a lot of people that are included in a home blood pressure monitoring program or a telemonitoring program. They measure in the morning and in the evening often. So do you think we should also regularly measure nocturnal blood pressure in these patients, even if they're on target in the daytime measurements?
Well, difficult to say in the sense that we know that nocturnal blood pressure holds important prognostic information, but we don't know yet whether targeting nocturnal hypertension can be of help and can be beneficial in terms of reducing cardiovascular events in our patients. This is obviously open to research, and we should focus our research on that. But what is the main problem with that? So developing a trial like this has a big issue. We need to confirm that the patient has nocturnal hypertension. We need to be sure that there is something going on during the night in terms of blood pressure control, because we know that ABPM allows us to measure, diagnose nocturnal hypertension, but if the reproducibility is not adequate, right? So using a home device can allow you to confirm whether the patient continues to have nocturnal hypertension over time. And these people probably are at higher risk of developing cardiovascular events compared to those that do have different patterns. But then again, this is still an unknown field. So we don't know whether if your patient have within 7 days, within 1 week, 4 or 5 days of nocturnal hypertension or just 1. We don't know which is the difference in terms of risk prediction in this patient, and therefore it's difficult to make recommendations on this, right?
Yeah. Okay. Thank you.
If I can add something, that's really an important issue, but in a way, we don't have to wait for something magic here, because we have plenty of evidence that if you reduce blood pressure, you prevent outcome, full stop. So nighttime pressure is just one component. It's not something different. It's part of the blood pressure control. So I think, don't need so much more evidence that this has to be done, because it's part of the hypertension care. The problem is how to do it and how often to do it, and in whom this should be done more systematically. And this we should also use our clinical experience and the check for comorbidities. Typically, if you have an obese person, a snorer, some evidence of apneas, diabetes, previous problem with the renal function, autonomic dysfunction. There are several situations where you know you might have troubles at night. So this represents an indication to go a bit deeper into that. And depending on technology, you can learn more. When we screen our patients, when they come for our hypertension center the first time, we try to have always an ABPM in all of them, just to start with something at baseline. But in particular, we have also a sleep center associated with the hypertension center. Those having any any evidence of sleep problems, they are supposed to go through this because they have a higher chance of having problems. So again, it depends on a kind of global clinical evaluation where you can identify those at higher risk. Please.
Thanks. So my question again is to Professor Pengo regarding the nocturnal home blood pressure measurements. So you showed that the device was taking a measurement 4 hours after the onset of sleep, at 2 a.m. and at 4 a.m. And my question was, are there data showing that those 3 time points are the ones that are most predictive of nocturnal hypertension, perhaps comparing with the regular 24-hour BP measurement studies that have been done?
Well, that's a very good question, actually. And it reminds me that we are trying to compare probably 2 different things, because nocturnal blood pressure measured by ABPM is something that we see on a night only. So again, a snapshot. Nocturnal blood pressure using a home device is something that we see on a long period of time, right? So I'm not sure that these 2 entities are comparable. Obviously, if you use a home blood pressure device, you cannot do a blood pressure measurement every 20 seconds as you do for an ABPM, right? Because otherwise this won't be feasible in clinical practice and the patient won't tolerate it at all, okay? The rationale behind having these 2 measurements is that you probably capture the real sleep blood pressure using these measurements that can be done automatically with a home blood pressure device, which is probably the real blood pressure that you want also to capture and to understand and to possibly treat in case, for example, as Professor Parati was mentioning, in a patient with sleep disorder breathing. So obviously we need more data, again, to compare and to understand whether these few measurements are enough, or if perhaps we need to slightly change the algorithm or improve it in a way. But it has been developed with the aim of capturing sleep blood pressure without waking the patient up, without disturbing the sleep too much.
I have a question about nighttime blood pressure. We have a lot of evidence that it's important, so no question about that. What is the difference between the 2 methods? If you have sleep blood pressure measurement with a home monitor or with an ambulatory monitor, one would say, why should you compare this? It's the same thing. Well, it's not the same thing, because ABPM is 1 night, but home is 3 nights. For example, the first time I came to this meeting, the first night, I didn't sleep well. And yesterday, I overdid. So potentially, do you think it's an advantage that these asleep readings are taken in different nights rather than 1 night? Because otherwise, it should be identical.
Yeah, I think so. And again, this can also open the floor to home nocturnal blood pressure variability, which is captured in a short term with the ABPM, but can be captured on a very long term with a home blood pressure device, which is something that we haven't been dealing that much because we haven't had the chance to capture nocturnal blood pressure with a home blood pressure device. So this will certainly be feasible in the future. Another thing that I think it is worth mentioning is that this tool might help us also understanding sleep patterns. And you know that the sleep quality is now one of the 8 life essentials according to the American Heart Association for Cardiovascular Health. And therefore, merging these 2 important data, so the sleep duration that we know is also an additional cardiovascular risk factor, reduces sleep duration, together with the continuous blood pressure monitoring during the night, can really perhaps help us describing the best we can nocturnal blood pressure profile of our patients.
I can maybe make an anticipation of future studies. We are recommending, when you're using home blood pressure monitoring, to do 7 days before the visit, and you calculate the average. Probably when we want to measure nocturnal pressure, why don't we recommend 7 nights as an average? Because we are not sleeping in the same manner every night. That's physiologic. So if you want to pick up what is the real burden of nocturnal blood pressure, probably you need to take into account this physiologic variability and come up with something which is more comprehensive and reflecting the burden. That could be something to consider. George, and then Roland.
Sorry to leave you waiting just a second. We've done that. We looked at different days with home monitors, and this is not like the day, because you know, when you take awake home measurements, the first day is high, the second is a little higher, and then there is a smooth, stable home measurement. This is not the case with nighttime. Nighttime is the same, right? Which is understandable from the same day. And my colleague, Tasso Scoli, has looked at the schedule, and it means that because of that, you need fewer readings than during daytime, because it's more stable measurement.
Thank you. Congratulations for that topics, crystal clear. My question is regarding the frequency of the measurement, exactly as you mentioned, Gianfranco. Very pragmatic. If I am interested I'm a clinician, I will go maybe once for ABPM. And if I look to the guidelines, we are saying that do as much as you can, let's say 1 measurement every 15 minutes. But at the same time, we are accepting only 7 measurements during the night as a quality control. And if I look to the data you showed with the Professor Paratini study, the standard deviation is also very interesting during the night. And I still remember your study, Gianfranco, we need absolutely 1 measurement every 15 minutes to evaluate the standard deviation. So my question is very pragmatic. How much we need to program the device, and what's the minimum number that we must accept to evaluate this night blood pressure? I am sure that 7 is not enough. What do you think?
Thank you for asking, and this is a debated issue. You know, we've been discussing this many times, and there is no full agreement, honestly. In the night, you have to aim at a compromise. So the need of having more frequent sampling, because of course you increase the accuracy in ways. You have some data in polysomnography when you detect sleep apneas, and you have a blood pressure rise lasting less than a minute. If you're measuring blood pressure every 15 minutes, you might not pick this up. You might have blood pressure peaks, and you will never see them, because the measurement is programmed in a different time. So that's one of the problems. But at the same time, we have to try to reduce the sleep disturbance. If you keep measuring too frequently, people don't sleep because they are not accepting and tolerating the calf inflation. That was the reason for this kind of recommendation of 7, which I was not fully in agreement, honestly, because I think it's too low. 7, you know, you might have a couple of artifacts, you are losing the information in many cases. But we have to consider the new technologies coming, and as George said, we can have more nights. So this might, in a way, compensate for the lower sampling rate, but this has to be investigated. Just going on the line where you were saying, George, in our data, where we were repeating nocturnal measurement with the home device, we found quite a variability. People who were maybe deeper in one night were becoming non-deeper in a second night and getting back to be deeper in another night again. Depends what they were eating, how much they were drinking, how was the sleep condition, they were snoring or not. There is some variability, which depends on other factors. Of course, if you are in a perfectly normal people, it might be more regular, but it's not always the case in the patient with comorbidities. That could be a problem. I don't know what you think.
I strongly believe that 7 is not enough. I believe in this. And I would like to just add just one comment about the devices and the kind of message for the manufacturer, since we are in a satellite symposium sponsored by the manufacturer. Again, the problem we are facing in our daily practice, you said, George, systematic screening in over 75 years old. And when you give the devices to people who are over 75 years, and you explain to them that you have to manipulate the device, you have to manipulate the EKG, you have to manipulate the app, because it's not only the device, there is an application. There is some mismatching between this elderly population and the high request, technical request of the device. They must be much more user-friendly, with the minimum intervention of the patient. This is a real problem we are facing in our daily practice. You give the device, you give the, even if you take the time to explain to the patient, you will lose a lot of them. I don't know your experience with this.
I'll go to the previous comment. One might argue that these few measurements with home monitors are much better than ABPM. Before we came to this meeting, one of my colleagues presented to me an abstract, and he was comparing home nocturnal versus home ambulatory. And he said we had 7 readings home nocturnal and 21 ambulatory. I said, you did a mistake. You didn't have 21 nocturnal readings for ABPM. And he checked the data and did. What I'm saying is that the home monitors, which do a sleep blood pressure, they do it in 3 days, and they compare with much more readings with ABPM, and they give the results that you show, which means that maybe the advantage of having 3 days, this method can compete with fewer readings versus ABPM. And of course, 6 readings are few, but they are much better than one might predict without looking at the data. The data are in favor that you can do with fewer readings when you do home measurements in different days than with ABPM. Think about all the direct comparisons, which are unfair in terms of number of readings, and home monitors did as good. I think it needs a little more research, but in my understanding, the data show to advantage of the home monitors because probably of the different days.
Thank you, George. I think we have, as you see, a lot of space for research, so you're all welcome to contribute with your studies, because that's an interesting issue, and the technology is evolving so quickly. Definitely, we also need to see what is the difference in terms of outcome prediction. That would be something to be assessed in a larger data set, but it's something definitely deserving to be investigated. So I wish to thank my co-chair, Professor Stergiou, and Dr. Pengo for their presentation, and thank you for coming here for this discussion. It was quite interesting. You gave us also some good ideas for future studies. I wish you a good continuation of the meeting.